glucocorticoid receptor antagonists and SGLT2 inhibitors and their indications according to the correct guidelines. Eugene, thank you for starting the recording. Thank you for all your sacrifices. So without wasting much time, we are going to start the presentation. I would like us to listen very well and also make the discussion post-presentation enriching by taking note of our questions, comments, and contributions, especially things we may have seen in the MCQs, so that we can discuss them and cement them further. Thank you so much, everybody. Dr. Felix, over to you. Dr. Felix. Dr. Felix. Hello.
Yeah, hello.
Yeah,
Hello.
okay. We're not hearing you, or I was not
Okay.
hearing you.
I think I was muted. Yeah, sorry
Okay,
for that.
okay, okay. All right. All right.
Yeah, so thank you very much. And like indicated, I'll do SGLT2 and mineralocorticoid receptor antagonist. And we'll be looking at the steroidal and non-steroidal antagonist. So by way of introduction, mineralocorticoid receptors, known as MRAs, have become one of the key drugs in the management of cardiovascular diseases. And this has really harnessed the pathophysiology of aldosterone and the function of aldosterone in the human body. So we'll go through a brief history. Aldosterone was first isolated in 1952, and then by 1957, the first spironolactone oral dose was produced and was launched as a diuretic in 1960 to treat hypertension and mostly primary aldosteronism. So by 1963, it was noticed that the spironolactone had some anti-adrenergic and then progestational symptoms. And those were decreased libido, gynecomastia, and then women also had abnormal menstrual problems. So quickly, the drive was to see if they could get another chemical like spironolactone. But then that did not happen until 1987 when they were able to synthesize eplerenone. And though it was less potent than the spironolactone, it did not have the side effects that spironolactone had. So it was almost a favorite at that time. So the aldosterone is part of the renin-angiotensin-aldosterone system. And for us to understand the function of the mineralocorticoid receptor antagonist, we need to understand this pathway. And I'm sure we've gone through it severally, pathophysiology of heart failure and the others. But then if we understand the role of aldosterone and when there is overactivation, then we can understand the pharmacology of the MRAs. But then generally, the RAS is involved in regulation of renal handling, fluid balance, osmolality, and renal blood flow and blood pressure. So basically, that is the function. And if we look at this diagram, whenever there's increased sympathetic discharge to the kidney, reduced blood pressure, for instance, hypotension, and then decreased sodium delivery to the tubule, the juxtaglomerular apparatus would detect that and secrete renin, which is converted to angiotensin 1, and then as it goes through the lungs, converted to angiotensin 2. And then that stimulates the production of aldosterone. And then that also stimulates the kidney and leads to what? Increased blood volume. That's a sodium and water retention.
Yeah.
Which leads to increased blood volume and cardiac output to restore the normal blood pressure and the systemic vascular resistance. So aldosterone is good for us, but the problem is when it's overactivated. When it is overactivated, that is when it becomes a problem. This diagram is just to illustrate what I just said. So the aldosterone, like I said, plays a key role, okay, in the electrolyte balance. That's sodium, potassium balance, blood pressure regulation. And then it has this effect on tissue remodeling. And this is done through complex molecular pathways. What we should know is that apart from the kidney, okay, aldosterone also has some other effects. So has some receptors in the salivary gland, in sweat glands, and in colon, where it is also involved in uptake of sodium and then release of potassium. So not just in the kidney, but then it is also found in other organs, including even the brain. So aldosterone itself almost is exactly the opposite of atrial natriuretic peptide that is secreted by the heart. It has a plasma half-life of about 20 minutes and responsible for the absorption of about 2% of the sodium that is filtered through the kidney. And that is estimated to be nearly equal the sodium content in human blood. That is under normal renal function. So we all know aldosterone is part of the mineralocorticosteroid system. So it is derived from cholesterol and goes through, just like cholesterol would go to the formation of cortisol, and the others, it also goes through the same chain of reaction until the last part where aldosterone synthase, that's C11B2, synthesizes aldosterone. Okay, and so that is why aldosterone has mineralocorticoid. So the mineral part and then the steroid components, because it is part of this pathway. But then this pathway is tightly regulated. So the renin-angiotensin-aldosterone system regulates this pathway. Potassium levels also regulate this pathway. So increased levels of potassium directly stimulate the adrenals to secrete aldosterone. So potassium is also involved in this in aldosterone synthesis. And then again, the aldosterone is known to be synthesized in extra-adrenal tissue. So in the heart, in the brain, aldosterone has also been found, discovered to be synthesized in those sites. So, but the majority of the aldosterone we have comes from the adrenal cortex. Okay, so I think I've spoken about this already. So this just illustrates that cortisol, corticosterone, and aldosterone are similar. If you watch, they have very similar chain structure. The only difference is the hydroxyl and the oxidized groups. So it undergoes oxidation, and that outcome is different from cortisol and corticosteroid. So what aldosterone does is that aldosterone goes into the distal renal tubular cell, okay, and then it binds to the mineralocorticoid receptor. And once it binds that, it is able to go into the nucleus of the cell. And once aldosterone is in the nucleus of the cell, it stimulates gene transcription. So it affects the gene that transcribes mainly two proteins. Okay. But apart from these, it also secretes other proteins that are pro-inflammatory. So one is the epithelial sodium channels that will be expressed. And then we also have the sodium potassium ATPase channel that is also expressed. Okay. And then it also secretes proteins that prevent these transport channels from being degraded. So apart from increasing the numbers, they are also protected, sort of. So, and that's, so what will happen is that, so once this is extruding 3 of sodium, so there's a net gain into the blood, and then potassium, 2 molecules moving into the renal tubular cell. On the opposite side, sodium is coming in through the epithelial sodium channel, and potassium is pushed out into the renal tubule through the renal outer medullary potassium channel. And that is how come the kidney loses potassium when we have higher aldosterone levels. Okay. It has been shown that aldosterone works effectively or exerts its remodeling effect when sodium levels are high and potassium levels are low. So in studies where they have supplemented potassium, high levels of potassium, aldosterone has not been able to effect its remodeling function. So it needs low or requires high sodium and low potassium environments to really exert its remodeling function. And then, like I said, it is not only aldosterone that is secreted once the mineralocorticoid aldosterone complex goes into the nucleus. It also leads into the transcription of co-modulators and other compounds that exert the other effects that aldosterone is known to do. So pro-inflammatory, pro-fibrotic proteins are released. And this leads to endothelial dysfunction, myocardial hypertrophy and fibrosis, remodeling, increased arrhythmia, decreases coronary blood flow, can also affect the kidney. Okay, so aldosterone, like I said, is good. It's only when it's in what? It's in excess. There's overactivation. That is when it begins to exert its effects. And we all know that from the neurohormonal pathway or activation of heart failure. And that is when it is secreted in excess. Okay, so I think I've gone through this already. All right, so again, this is what we want to avoid. Okay, and that is why we need to find a way to stop aldosterone from doing this. Okay, so the cardiac fibrosis, vascular inflammation, that has to be controlled. So in heart failure, that will go on if it is not checked. In the hypertension or renin secreting or primary aldosteronism, we need to be able to stop this from happening. So then mineralocorticoid receptor antagonists were discovered. Okay. And these are competitive inhibitors of aldosterone on the mineralocorticoid receptor. Okay. And once they bind, they prevent aldosterone from attaching to its target site. And once aldosterone attaches to its target site, that is when gene transcription and other things happen. In addition, apart from the gene transcription, it's also known to have other non-genomic effects. So the gene transcription upregulating the sodium potassium channel or the epithelial sodium channel are the genomic effects of aldosterone, but it is also known to have other non-genomic effects. And that is usually when it's able to act rapidly on the cells to increase sodium reabsorption and then potassium excretion, whilst it is affecting the transcription process, which takes some days to be effective. So if we are able to block the effects of aldosterone, so various pathways have been looked at. So one is the aldosterone synthase inhibitors, and there is a drug that is being tried now. The other option is to block the MRAs. That is one. And then the other thing is, once the MRA binds to the receptor, is there a way to prevent it from affecting the change that is supposed to do? That is also another pathway that has been explored. But for now, what we have is the MRAs that we have to. So MRAs, generally, there are two classes. We have the steroidal MRAs and the non-steroidal. So steroidal, we have spironolactone, eplerenone, and canrenone. Canrenone is actually a metabolite of spironolactone. It's one of the active metabolites. And in some countries, like Italy, in Europe, they actually have it as a drug. And it also comes in an IV form, but it is not available in the US. Then we have the non-steroidals, which is not based on the steroidal backbone. Okay, but it also has an effect on the mineralocorticoid receptor. And this includes phenyrenone, apalerenone, and then isazerinone. Isazerinone currently is approved in Japan, so it's being used in Japan. Apart from Japan, other countries are not using it yet. The main difference is that the steroidals derive from progesterone and the spironolactone analogs. So it has a steroid backbone, whilst the non-steroidals do not have a steroid backbone. Okay. And then these were the first agents to be produced, and they are competitive inhibitors of the binding site of aldosterone. The non-steroidals also competes, but doesn't actually bind to the binding site of aldosterone. It actually binds to the complex of the mineralocorticoid receptor in aldosterone and then causes a conformational change. So it is not able to exert its gene transcription or genomic effects on the renal tubular cells and other cells. Okay. So the first generation of mineralocorticoid receptor antagonists, first is spironolactone, which is a steroidal. The second generation is eplerenone, and then the canrenone, which is the prodrug of the canrenone. And then we have the third generation, which is the phenyrenone and the isazerinone. So these are the generations of mineralocorticoid receptor antagonists that we have. So I think I've explained this already. So the genomic effect is that aldosterone binds and then induces transcription and activation of target genes. And this leads to proteins that are synthesized, involves sodium reabsorption, potassium excretion, and then we have the pro-inflammatory, pro-fibrotic proteins that are also released. Non-genomic effects usually do not involve gene transcription, but these are the signaling cascades that happen within the cell, and that also leads to absorption of sodium and excretion of potassium. But then there's no gene absorption involved here. So spironolactone was discovered in 1959, almost 65 years ago. And then at that time, very potent, competitive, still potent, okay, but it has a high affinity also for the mineralocorticoid receptor site, okay. So what it does is it actually binds to it, okay, and then what it does is that it binds and then it dissociates. But in doing that, it destabilizes the mineralocorticoid receptor. So aldosterone is not really able to bind to it. That is how come it exerts its effect. But then the other thing is that it also binds androgen and progesterone receptors if significantly. And that is where it has these off-target effects of gynecomastia, impotence, decreased libido, abnormal uterine bleeding. Okay. So spironolactone is absorbed rapidly from the GI tract. Bioavailability is about 60 to 90%. Onset 2 to 4 hours. The suspension has an earlier onset. And in fact, duration of effect of spironolactone is up to 2 to 3 days. Okay, up to 2 to 3 days. It is highly protein bound. It's highly protein bound, and the metabolites are even have a higher affinity for proteins. It is rapidly and extensively metabolized by the liver, and usually through first pass metabolism, you have all the active metabolites, and its long duration of action is based on the long life of the active metabolites. So we have the canrenone, we have the 7-alpha thiomethyl spironolactone, the 6-beta hydroxy 7-alpha thiomethyl spironolactone. And these are the active metabolites of spironolactone. The kidney also does some metabolism of spironolactone, but not as much, mostly done by the liver. Half-life is about 1 to 2 hours, but then the metabolites have a longer half-life, and that is why it has a long half-life. Secreted through the urine and the feces, and these are the metabolites that are usually. So spironolactone, once it gets into the cell, binds to the mineralocorticoid receptor, okay? And then once it binds to the mineralocorticoid receptor, it prevents aldosterone from exerting these effects that we have spoken about, okay? And once we don't have potassium coming into the cell and sodium going out, we do not have enough potassium leaving the renal outer membrane potassium channel. So the potassium stays in the blood, and then we have less absorption of sodium. So sodium that is secreted or filtered into the tubular lumen stays in there. It is not brought into the cell and into the bloodstream. So clinical uses of spironolactone, heart failure, reduced ejection fraction, resistant hypertension, has other non-cardiac uses, liver cirrhosis, nephrotic syndrome, primary aldosteronism, and then has off-label uses for acne, polycystic ovarian syndrome, hirsutism, and then female pattern hair loss. And it's even been used for feminization in other places. Side effects: abdominal cramps, diarrhea, can cause nausea and vomiting in some people, drowsiness, headache. Some people develop a hypersensitivity reaction to it. Amenorrhea, gynecomastia, hyperkalemia, which we all know is the most common cause. Agranulocytosis, and then it has been reported to cause malignant neoplasm in some cases because of the off-target activity of spironolactone. Contraindications: we do not use if hyperkalemia, potassium more than 5.5, strictly contraindicated. If there is a history of hypersensitivity, a patient with Addison's disease or other conditions that come with hyperkalemia, it is contraindicated. And then not to be co-administered with eplerenone. Okay. So I'll move on to eplerenone, which is a more selective mineralocorticoid antagonist, but then it has low affinity for the androgen and the progesterone receptors. So that is the good thing about eplerenone. But in some cases, it can lead to those side effects, but it's very minimal. Okay. It also binds to the mineralocorticoid receptor like spironolactone, and then causes the active conformational change. But then it is known to be less potent compared to spironolactone. And then it has no active metabolites. That is eplerenone, no active metabolites. Well absorbed, peaks within 1 to 2 hours, and the bioavailability about 69%. It is protein bound, so 50% of it is protein bound, and that is the advantage it has because it means that you have about 50% of it in the bloodstream that moves around and can effect some change compared to spironolactone, which is tightly protein bound. Very large volume of distribution, about 43, depending on the individual, to 90 liters. Okay. It is inactivated in the liver by C3A4A, and the half-life is about 4 to 6 hours. Eliminated, so half-life is about 4 to 6 hours. 2/3 of it excreted in urine, and then about 1/3 in feces. So inhibitors like C3/4A, clarithromycin, itraconazole, other antifungals would increase the blood levels of eplerenone, whilst inducers like carbamazepine, rifampicin would decrease the efficacy of eplerenone. Common side effects can cause hyperkalemia, abdominal pain, diarrhea, dizziness, fatigue, malaise, cough, abnormal vaginal bleeding, gynecomastia, and mastodemia. But like I stated, not as much as spironolactone does. And then in some individuals, hypercholesterolemia and hypertriglyceridemia. Clinical uses: moderate to severe congestive heart failure, post-infarct left ventricular dysfunction, and that is from the Ephesus emphasis trials, and then also in hypertension. So contraindications: hyperkalemia, liver dysfunction, patients with metabolic or respiratory acidosis, renal impairment. If there's history of hypersensitivity, it should also not be used, and then not be used concomitantly with strong CYP3A inhibitors. Okay, so those are the two main steroidal mineralocorticoid receptor antagonists we have. And then for the non-steroidal, we look at finerenone. Finerenone is a non-steroidal type, like indicated, and surprisingly, is actually a dihydropyridine-based non-steroidal. So has a very high affinity for the mineralocorticoid receptor, more than spironolactone and eplerenone, and then specific like eplerenone. So very potent and very specific. Okay, so in the US, it is the only one approved, but like I stated, the Zerinone is licensed for use in Japan. Okay, so finerenone was accidentally discovered. So in 2004, Bayer decided to run a screen, okay, what they call a ultra high output screening program. So they took 1,000,000 compounds and just run in vitro to see if they would have some effect, either enhancing or antagonistic effects. And then the surprising thing was that this chemical, which became finerenone, a dihydropyridine, actually blocks the L-type calcium channel blockers, had an effect on the mineralocorticoid receptor. Okay, so through refining it, they eventually optimized and then identified finerenone as a potent MRA antagonist, MRA. So it's as potent as spironolactone and very selective. Okay, it's about 500-fold selective than eplerenone, so quite selective, and that is why it hasn't got the other off-target side effects. Okay, so it blocks the mineralocorticoid receptor mediated sodium reabsorption. So So it's actually bulky. So it binds to the mineralocorticoid receptor. And what it actually does is that it inhibits the transcriptional cofactor. So once it binds, the aldosterone will still bind to the receptor, but then it also binds to the aldosterone mineralocorticoid receptor complex, okay, and then prevents the recruitment of transcriptional cofactors. The advantage here is that when spironolactone binds to the receptor, to some extent, there's still translation or transcription of some of the cofactors that have pro-inflammatory and pro-fibrotic effects, but it is not as much as aldosterone does. But then what finerenone does is that it prevents expression of any pro-inflammatory or pro-fibrotic proteins. So that is the advantage that it has. It has no affinity for estrogen, androgen, or glucocorticoid receptors. And the interesting thing is that the distribution is equal. You have equal amounts in other tissues, in the heart, in the kidney, unlike spironolactone, where you have more of it concentrated in the kidney. So this is the mechanism of action of finerenone. So aldosterone binds and it binds to the and then you have cofactor complex activation. But then what happens is that once it binds and comes here, finerenone also binds to this complex and prevents it from transcribing the target genes that lead to the deleterious effect of excess aldosterone. Okay. Bioavailability about 44%, steady state in 2 days. It is also highly protein bound. Usually, it mostly bounds to albumin. Also metabolized by the CYP3A4A, that's about 90%. The CYP2C8 also does that, and also has no active metabolites. Okay, 80% secreted in urine, and about 20% of it is excreted in feces. Okay, side effects: it is able to cause hyperkalemia too. So can cause hyperkalemia, hypotension in some cases, and hyponatremia. Contraindicated, should not be used concomitantly with strong CYP3A4 inhibitors, and especially grapefruit or grapefruit juice is known to be a strong CYP3A4 inhibitor. So you would have excess amounts of finerenone. And then in patients with adrenal insufficiency, it is also contraindicated. Okay, so this table is just comparing the pharmacokinetics of eplerenone, finerenone, and spironolactone. Okay, and see that potency, selectivity, binding mode high for the finerenone. Okay, potency high for spironolactone. Okay, and then we look at the tissue distribution. Spironolactone is about 6 times higher in the kidney compared to the heart. Eplerenone about 3 times higher, but then finerenone has the same a balanced distribution. It has a balanced distribution. Okay. So quite a number of trials have been completed, and a few are ongoing. So for the steroidal mineralocorticoid receptors, they have really been proven to be of use in ejection fraction, heart failure with reduced ejection fraction. And for now, we have the rails, emphasis HF. We also know FSOS has been completed, ARTS HF has been completed. And then, yes, and then we also have TopCat, which was completed. That was also a trial for heart failure with preserved ejection fraction. And we all know the history behind the TopCat trial. Then Fine Arts HF was completed, I think, last year. So the results were published last year. Currently, we have Finality, which is ongoing, finerenone in patients intolerant to or ineligible for steroidal mineralocorticoids. So as an alternative to the steroidal MRAs. Also ongoing, we have Spirit HF, spironolactone. We have Spirit 2RR, spironolactone ongoing. There is Redefine. And then there is a polydiuretic therapy for heart failure with preserved ejection fraction. There's also the confirmation that is combining finerenone and empagliflozin. And then there's a balanced DHF, which is combining DAPA and it's supposed to be DAPA and finerenone to see the outcomes. So these are the trials that are some have been completed and some are currently ongoing. We all know of RAILS, Ephesus, and Emphasis. And Ephesus, Emphasis in acute coronary syndrome, myocardial infarction, heart failure. RAILS, heart failure. And then this from RAILS. So Ephesus was the first trial to show benefit of aldosterone antagonists after acute MI with heart failure. After acute MI with heart failure, eplerenone was used in that study. We have, so generally, RAILS for heart failure, reduced ejection fraction. They use New York Heart Association class 3, class 4. Emphasis, Ephesus, also dysfunction, heart failure, but for Ephesus, acute myocardial infarction. So Emphasis, this is Emphasis trial, and they showed clinical benefits in patients with systolic heart failure, mild symptoms initially shortly after hospital discharge. So this is the Emphasis. Then finerenone in heart failure with preserved ejection fraction. So that was a trial that ended last year, and the results were published. It was actually published last year, I think about September, the trial, yeah. So, and the conclusion was that in patients with heart failure and mildly reduced or preserved ejection fraction, finerenone resulted in a significantly lower rate of a composite of total worsening heart failure events and death from cardiovascular causes than placebo. Then this is the ARTS HF that looks at, so it was a head-to-head finerenone and eplerenone. So, and that also looked at all-cause death and cardiovascular hospitalization. So it was also shown, so this is cumulative probability of all-cause death. So finerenone was better than eplerenone, as shown here. And then they pooled, so what they did was that they administered eplerenone in different doses, okay, 10, 20. So here was the pooled data for finerenone, but this was for eplerenone, and in all of them, it was much better, superior to eplerenone. So these are the trials I've listed. There's also the Fidelio and the Figaro trial, and that is looking at in kidney failure and then cardiovascular events, including heart failure, hospitalization in patients with CKD and type 2 diabetes. That's the Figaro DKD. So the fine arts, this is the conclusion from that. Okay, so mineralocorticoid receptor antagonist, eplerenone, spironolactone, have shown benefits across the spectrum of cardiovascular diseases. And we've seen the various trials that have elucidated this effect. Okay, so there's the top cut. initially there was no difference, but then what they found out was that the samples from Russia and Georgia, they actually went back to the urine samples to see if they could find the active ingredient, canarum, and then realized that the samples from Russia and Georgia didn't really have the active ingredient. So a lot of the data we have now is the American data. They've actually taken out the Russia and then the Georgian data. So that seems to suggest that, but then the main thing was that the only significant difference was heart failure hospitalization, which had a p-value of 0.04. Even though there are reductions in all-cause mortality, cardiovascular mortality, the p-value was not significant. So guideline indications. So for patients with mildly reduced ejection fraction, an MRA may be considered for patients with heart failure with mildly reduced ejection fraction to reduce the risk of heart failure hospitalization and death. So this was the 2021 ESC guideline. Okay. Then an MRA is recommended for patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. And that's a class 1 indication, ESC 2021. Then, for the management of heart failure with mildly reduced, that I have already indicated. Then for phenylenedione, so for patients with type 2 diabetes, CKD, phenylenedione is recommended to reduce the risk of heart failure, hospitalization. And that this was from the focused update. That's the ESC guideline on the heart failure. This was a focused update that phenylenedione became a class 1 indication. Okay. The American guidelines also have similar indications. Recommendations for mineralocorticoid receptor antagonists is a class 1 indication for patients with heart failure, reduced ejection fraction, class New York Heart Association class 2 to class 4 symptoms. Okay, so it's recommended to reduce mortality, morbidity, EGFR of more than 30 mils per minute, serum potassium less than 5. Okay, and then in patients with heart failure, reduced ejection fraction, New York Heart Association class 2 to 4 symptoms, MRA therapy provides high economic value. So there's a value statement, high economic value. So in the long run, it's supposed to reduce hospitalization, supposed to reduce mortality. So in the end, we are saving. Okay. So in patients, so this is harm. In patients taking MRA whose serum potassium cannot be maintained at less than 5.5, MRA should be discontinued to avoid life-threatening hyperkalemia. Okay. So far we've seen the evidence support for use of MRA and then their function in varying degrees of heart failure, mostly reduced ejection fraction, other cardiovascular diseases, and with a new non-steroidal, its use in heart failure with preserved ejection fraction. Okay. So I'll move on to the pharmacology of SGLT2 inhibitors. Okay, so these are inhibitors of the sodium cotransporter. They were first marketed in 2013 for treatment of diabetes. And that is because of their anti-glycemic effect by inhibiting the absorption of glucose in the tubular lumen. To date, we have about 8 of them now. 4 have been licensed for use in the heart failure. But then so far, the guidelines, we only have DAPA and empagliflozin. Probably with the new guidelines that might be coming out, we would have a lot more of them being added. So for gliflozin is still undergoing some clinical trials, but the others have passed phase 3. So the SGLT2s are in the proximal convoluted tubules of the kidneys, and that is where they contribute to absorbing filtered glucose. They absorb filtered glucose. The first segment of the SGLT2 actually absorbs about 90%. Okay, that's the SGLT2 absorbs about 90% of glucose, and the SGLT3 that's about 10%, and that is in the lower segments. So about 90% of filtration happens in the proximal tubule, and that is by SGLT2. Okay, so the inhibitors, the mode of function is to inhibit the SGLT2. Okay, it usually absorbs, it's a co-transporter, absorbs glucose and sodium. So what happens is that once it inhibits that transporter, then glucose stays in the lumen. Okay, and that is a proximal convoluted tubule that more than 90% of your glucose is absorbed. So down the chain, virtually we shouldn't have glucose in our urine. So it absorbs almost everything. So what it does is to inhibit SGLT2, and then glucose stays in the lumen throughout and is passed. But then, in addition to that, what happens is that sodium cannot move into the cell. So sodium also stays within the lumen. So a pathway for sodium absorption is also inhibited. So we have sodium also staying in the lumen and also being passed out. Okay. So, and that also affects the sodium potassium pump. So sodium is not pushed into the cell, and then potassium into the basolateral cell or the tubular cell. Once potassium comes in, it has to go through the ROMC, that's the renal outer membrane potassium channel, if it is in excess, to balance the gradient. So this also prevents potassium from moving into the cell, into the lumen. Okay, so the effects of SGLT2, and these are known to be the mechanisms that are beneficial to the heart. So they have direct myocardial and indirect systemic effects. So it is postulated that through its effects, it reduces inflammation. There's autophagy, mitophagy is increased, decreases this compound, that's the sodium hydrogen exchanger. Okay, and all this contributes to a better heart health or improved heart health. So also decreases the effect of the sympathetic nervous system on the heart, improves glucose use, so it redirects the use of glucose. Then there's increased epoetin, which also contributes to well-being symptoms. So more blood is produced, and patients are less symptomatic. So what that does is that there's decreased glucose sodium reabsorption, which we have seen. There's decreased metabolic demand, increased sodium in the distal tubule. There's reduced renal blood flow, and then there's reduced oxidative stress. And that is the effect of the SGLT2 on the body, and eventually that leads to some cardiovascular benefits. Okay, so we can look at this later. So for the vasculature, there's decreased inflammation, decreased blood pressure, increased provascular progenitor cells, and the improved vascular function. If we come to the heart, we have looked at that already. So that is the postulated mechanisms of SGLT2 inhibitors to the heart and to the whole body in general. Okay. And this slide I got from the previous presenter, I think Dr. Abubakar. That's the effect of SGLT2, cardiovascular protection, and the pathways that are being postulated. So once there's decreased intraglomerular hypertension, decreased albumin is being secreted, you have blood pressure, reduced arterial stiffness, and that goes to reduce the cardiac afterload and eventually reduces what? The left ventricular remodeling. In the kidney, we also have decreased renal and systemic inflammation, and that also reduces the cardiac remodeling. So we have less fibrosis happening there. Then, because of the preservation of systemic and sodium water homeostasis, you don't have so much sodium being absorbed with water being absorbed into the system. There's maintenance of euvolemia. Okay, that is for the patient with heart failure, and that contributes to what? Reduced risk of hospitalization for heart failure. They don't get decompensated to be admitted. That also leads to what? Decreased cardiac preload, decreased myocardial wall tension. And we know that contributes to reduced what? Myocardial oxygen demand. Okay. And also the reduced wall tension can also reduce left ventricular remodeling. Okay. To reduce the tension, the heart has to open up. That reduces it. So it's also known to reduce arrhythmogenesis. So we do not have arrhythmias occurring. And like we saw the previous slide, it has an effect on the stimulation of the heart by the sympathetic nervous system. So it actually dampens that effect. Okay. So cardiovascular benefits of SGLT2s we know was first seen with the DAPA-HF and Emperor-reduced trials, and they demonstrated that these medications had some effect on all-cause mortality and cardiovascular death. Okay. So SGLT2s are well absorbed from the gut and advised to be taken before meals. SGLT2 inhibitors have high plasma protein binding, but then the different SGLT2s differ in their binding potential. So DAPA, about 91%, canagliflozin has the highest, which is about 99%. Their volume of distribution also differs across board. Okay. So they actually undergo transformation by glucuronidation. Okay, that's how come they are glucurinated and then eliminated out of, they excreted out of the body. Okay, and it is thought that there's a cytochrome P450 mediated metabolism, which is very minimal, but a lot of it undergoes biotransformation, filtered from plasma, the glomerulus, and that is where it actually attaches to the lumen. So you need to have a functioning kidney for you to be able for SGLT2 to work effectively. So this is just to emphasize the different roles of SGLT2 inhibition. Okay, so in heart failure with preserved ejection fraction, these are the mechanisms that are being postulated. The main mechanism is reduction of oxidative stress or inflammation, and that increases by increasing the nitric oxide bioavailability and other signaling pathways and reducing the pro-fibrotic, pro-inflammatory pathways. And that is how come it is beneficial in patients with heart failure with preserved ejection fraction. Actually improves the diastolic function. Okay. What are the clinical indications? We all know mostly was for diabetes, and cardiovascular benefits have been were discovered subsequently. And that is because of the cardiovascular safety profile trials that every medication has to undergo through. So any medication that is coming, any trial, you have to ensure that it is safe. So cardiovascular wise, it is safe. And in doing that, they found that it was beneficial to the heart. Okay, so ESC guidelines, dapagliflozin or empagliflozin are recommended for patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. So that is a class 1 indication. In the focused update, SGLT2 inhibitor, they stated dapagliflozin and empagliflozin is recommended in patients with heart failure with mildly reduced ejection fraction to reduce the risk of heart failure, hospitalization, or cardiovascular death. And for heart failure with preserved ejection fraction, it is also a class 1 indication and a level A evidence. Okay. The American College of Cardiology, okay, recommendation for SGLT2, okay, in patients with symptomatic chronic heart failure with reduced ejection fraction, SGLT2 inhibitor are recommended to reduce hospitalization for heart failure and cardiovascular mortality, irrespective of the presence of type 2 diabetes. Okay. Then the value statement here in that in patients with symptomatic chronic heart failure with reduced ejection fraction, SGLT2 inhibitor therapy provides intermediate economic value. Then in patients, so the management of diabetes, that's for this. So in patients with heart failure and type 2 diabetes, the use of SGLT2 inhibitors is recommended for the management of hyperglycemia and to reduce heart failure-related morbidity and mortality. Okay. Then for primary prevention of heart failure in patients with risk factors for its development, so a patient with diabetes, obesity, hypertension with a risk, okay, for developing heart failure, SGLT2 inhibitors, canagliflozin, dapagliflozin, empagliflozin, etugliflozin, sotagliflozin are recommended in patients with diabetes at high risk of cardiovascular disease or with cardiovascular disease in order to prevent heart failure hospitalization. Okay, interesting. It says prevent heart failure, but then this is heart failure hospitalization. So whether you can use it in heart failure, I'm not too sure. But with other indications, it was just dapagliflozin and empagliflozin that was mentioned. Then it's used in specific populations because of the glucuronidation in the heart by the liver. It's used, you have to use cautiously in patients with liver impairment. Okay, pregnancy, they are contraindicated due to evidence of toxicity in animal studies. And this is said to be in second and third trimesters. So for pregnant females, it is better to use other medications that have a safety profile or a better safety profile in pregnancy than SGLT2 inhibitors. Okay, it is known for breastfeeding mothers. It is not recommended. It is not recommended. Okay, due to potential risk of infants developing the kidney. So pregnancy, breastfeeding, not recommended. So the concern was also for older people because of the reduction in the intravascular volume, creating hypotension. But then the sotagliflozin trial, that's a SOUL study, found that they were safe and effective in older people. So we can use them. Side effects, common is female genital fungal infections, urinary tract infections, and for some people, they have increased maturation because of the glycosuric, because of the osmotic, because of the inhibition of glucose absorption in the kidney. They tend to some patients actually urinate quite a bit. And we all know it is also has some diuretic effect. Okay. So other side effects have been reported. Diabetic ketoacidosis, commonly euglycemic decay, has been reported. Others, hypoglycemia, hypersensitivity reactions, but then they are not as common as these, the female fungal urinary tract infections and the increased micturition. Okay, so same slide. So these trials, patients with type 2 diabetes, cardiovascular inhibition of cardiovascular disease. Okay, this is for in patients with type 2 diabetes. So these are the various trials that have been used. Empire, Canvas, Declare Timmy, all of them have looked at that. Okay, then these trials, DAPA-HF, Emperor, Preserved, the Deliver trial, all these have been used for heart failure. These have been for heart failure. So these are trials we need to remember that supports use of SGLT2 inhibitors in heart failure, reduced ejection fraction, heart failure, preserved ejection fraction. Okay. Thank you. So I will, if there are any contributions from seniors, colleagues, please, you're welcome. Thank you.
All right. Thank you so much, Dr. Felix. Thank you for an excellent and well-delivered presentation. Thank you for the time it took you to put together such a good presentation. It's now time for questions and comments from the class. Before we go to questions or comments from our facilitators, our teachers. I don't know, does anybody have any questions? Or any comments? Dr. Felix,
Yes.
let me just start. I want to ask you something. I want to know, because when you talk about the MRAs and heart failure, actually heart failure with preserved ejection fraction, of course,
yes,
you said for reduced, it's class 1. For
yes,
mildly reduced, it's class 2A, I think it's 2A.
There's now 2A, yes.
Yes, then for preserve, is there any rule? Is it a 3 or a 2B, or they just kept silent on it? I don't know.
So the current guidelines for preserved ejection fraction is stage class 2B.
2B, okay.
2B, yes. If you saw the table, the focused update, that's a 2023 guideline. Yes, it's a 2B. 2B.
Okay. Thank you. Any other questions? Then, okay, so I know you went through it, but I'd like you to, actually for the MRAs, go over if you can go over the trials again, especially the key ones that we need to know if we are asked to discuss this topic, or like in a Viva station. Just go over like the rails, the Ephesus, and the emphasis. Those 3, if that's okay.
So, okay, so rails looked at patients with severe heart failure. That's New York Heart Association class 3 to 4, and left ventricular ejection fraction less than or equals to 35. And what they use was spironolactone and placebo, what the patients were already on. And the outcome was that it was reduced all cause mortality and hospitalization for heart failure. So that is the reals from the table presented. Emphasis looked at use of eplerenone and placebo. Okay. And that also looked at heart failure with mild patients with heart failure. And then there's a mild heart failure. That's symptomatically. So that was New York Heart Association class 2. But then they had an EF of less than 30, And in those patients, again, MRA was shown to reduce cardiovascular death and hospitalization. Then the FSOS was for patients with MI with reduced ejection fraction. So EF less than 40% and heart failure symptoms. And then that also showed mortality reduction, that is cardiovascular and all cause. Top cuts, like I indicated initially, was for preserved ejection fraction, but then the initial analysis really didn't, just showed some not significant differences, but then they felt that there was a problem with the trial, so they went back to audit it. And then fortunately, they had stored the urine samples of the patients in the trial. So they analyzed the samples for the metabolite of spironolactone, canrenone, and realized that the patients from Russia and Georgia did not have the metabolite, which means that a lot of them were not taking the medication. So the analysis, subgroup analysis, they actually took out those patients, and that's how come spironolactone was given a class 2B indication for heart failure with preserved ejection fraction.
Yeah.
Then the other ones we need to look at will be the ARTS HF, and then the Fine Art. Fine Art came out last year. Fine Art was last year. Okay, and that looked at heart failure with mildly reduced and preserved ejection fraction. And phenylalanine was showed reduced worsening heart failure. Okay. And then death and cardiovascular, all-cause death and cardiovascular death in patients with mildly reduced and preserved ejection fraction. So I think these are the trials we should pay attention to. And then
all right. So thank you so much. Thank you. Very well, excellently done. Then I also wanted to ask, is there like a timeline? Like, I know Rails came first in the 1990s. And I don't know whether you know the timeline for the others, FSOS, emphasis, Topcat.
Yes, so I think let's see, Rails was 99. I think Rails was in 1990, was in the 90s. Let me see if I can get that. Topcat was published in, yes, Rails was 1999. Topcat was, I think, was in 2013. FSOS, I don't remember FSOS, but one of them was 2003. Yeah, 2003.
Okay.
Let's see if I can get that. There was an image with the timelines. I'll look at it and share it. Yeah, emphasis was 2015. Fine Arts 2024. Yeah.
Okay. Because when discussing this, it will be good to like start from, you understand, the earliest to the latest.
To the latest, yes.
Then, so it's like I'm asking too many questions. I also want you to do the same thing you did just now.
Yes.
Do it with the SGLT2. Do it with DAPA HF, Emperor reduced, Emperor preserved, and deliver. Let us also be able to put it together.
Thank you. To put together. Yes. So I think that table just shows the order in which they were done. But I think DAPA HF was the first one, and then the Mra followed. Yeah, I didn't look at the order, but looking back, it was done. DAPA, Mra reduced followed. Yes, Mra reduced followed, and then we had a liver. I think the liver came later. Let me just go to that table. Yes, so DAPA Mra reduced, then there was Mra preserved, and then I think the liver was the last one. Yeah. So I think there's a hand up.
Thank you. Thank you so very much. Thank you for the presentation. Thank you for your excellent responses. I don't know, do we have more questions, contributions, or comments, or gray areas you'd like him to clear out? Okay, there's a hand up. Sorry, Dr. Lai, please go ahead.
All right, thank you, Dr. Felix. I hope I'm audible.
Yes, please. I can
Yes, you are.
All right, thank you for this well and lucid presentation. My concern is concerning the SGLT2 inhibitors. Is there anyone that have advantage over the other in terms of like MACE or male outcome, major adverse events? Because at times it seems there's a particular study, if I could remember, Canvas study that talks specifically on canagliflozin, saying that it's not so good, especially when you are considering comorbidity like DM in terms of causing more of amputation. Though there's another study, so maybe it's Candace or something like that. I want you to share more light on it if we can put them together, so that it won't just seem as if we have a generalized side effects or generalized poor outcome from putting all the class together. Is there anyone that is specific to a particular one of them? And is there anything that makes one to be more, to be better than the other one, apart from the absorption rate that you made mention of? Thank you.
Yes. So so when I looked at the canvas was mostly done in the type 2 diabetics. Yes, type 2 diabetics. Yes. But then in terms for use in heart failure, if you look at the guidelines across boards, so across societies, it is DAPA and EMPA that have been indicated. I don't know if with the new guidelines, they would add others, but these are the two that have been indicated. The others, Cana, Sota, Gliflozin, those mostly for prevention of heart failure. Those are prevention of heart failure. So in terms of the main two, DAPA, EMPA, I'm not sure which one is superior to the other. For canagliflozin, like you mentioned, higher incidence of amputation, but I'm not sure if one is more superior to the other in terms of heart failure. But I just know the two as the only ones that have been recommended. I'm not sure if someone else has any insight into this.
Yeah, I think it's like you said, for heart failure, it was just DAPA and EMPA. Okay, the other ones, like you said, are just for either diabetes, patients with heart failure, or prevention of cardiovascular events, patients with heart failure, or treatment of comorbidities, that's treatment of diabetes in patients with heart failure. But for heart failure, it's just DAPA and EMPA. And out of the two of them, I don't think they mentioned any specific thing that made it possible to choose one over the other. They are just both the same. And so with the newer guidelines, we'll know if we are to use the other ones. But the other ones for now are just for treatment of diabetes in patients that are indicated as class one in patients with spondylitis. So I don't think that's my own.
And I believe it's just data driven. It's a data that has that they are using. I'm not sure of any other reason. Yeah.
Yeah. Yeah. Or Dr. Laiwanja, I don't know whether you want to say something else or any other person wants to add a comment, I call Chief copy
Hello,
to make one
Dr.
or two
Charles.
comments. Yes, sir.
Dr. Charles, good evening and good evening, presenter. Thank you very much for the very lucid and eye-opening presentation. It was really clear and understandable. Talking about there's advantage of one over the other. I also don't think there's advantage of one over another as specific to heart failure. But maybe when you put other things into context, like looking into the renal function, so I think one may be advantageous over the other. I think DAPA, the cutoff for the EGFR is about 30, while for EMPA is about 20. So I think that may just be one of the differences you may look into when managing patients with heart failure and maybe kidney affectation also. Thank you. Otherwise, thank you for the very lucid presentation.
Thanks for the presentation, Dr. Felix. I think in the last national update, I think I didn't really get the source, but one of our teachers there mentioned that EMPA is good for a wider range of EF. It said as a wider range of EF between 50 to 74 compared to DAPA. So EMPA can cover from between 50 to say 74. So, but for EMPA, usually for that it covers for more, maybe like 50 to 60. But I didn't really confirm the source. I think one of the lecturers mentioned this during the update, said that EMPA is better. It covers a wider range of EF than DAPA. It didn't really say the value, but it said EMPA covers a wider range of fraction than DAPA. So we said EMPA is actually preferred to pick one. EMPA is preferred.
And I think for EMPA2, the advantage in patients with diabetes is that you can increase the dose, and some of them, unlike, so for EMPA, you can go to 20 instead of just doing 10. But whether for heart failure specifically, it has any advantage at a higher dose, that I don't know.
I think the study for heart failure is 10. I don't think there is any increment as it pertains heart failure. I think it's 10 for the studies.
And then I also sent a slide to the group, slide that we give to during that update. And they actually said you can check those landmark trials in cardiovascular medicine in one site. I think cardiologytrials.org or something.
Please, Dr. Fudo, please increase your voice. Please increase your voice, please.
Okay.
Go ahead.
Hello, can you hear me now? Hello?
Much better.
Okay, thank you. I said I sent a slide to the group, the slide that was given to us during that update. And the lecturer that presented that gave lectures on these cardiology trials said there's a site that where we can see everything. I think the site is in that lecture note. I sent it to the group. I think cardiologytrials.org, that's the site. In case one wants to further search on the different cardiology trials. Thank you.
Yeah, thank you so
Hello.
much for.
Okay.
Yeah, I heard you very well. Thank you. We heard you. Thank you for the contribution. Thank you for the slide that you sent too. Very helpful. I don't know whether we have more comments, questions, before we go to our MCQs. Chief Okopi, please, I don't know whether you have anything to add to the presentation. Yeah, let's see.
All right. Thank you so much, Dr. Okorie, for your leadership. Thank you again, Dr. Felix. Your presentations have been very sparkly. Thank you for the time you put together to make this presentation. Very detailed. Very. I think you touched it. Time is the exam that you guys will be going for. If it were to be the previous examiner, you could have predicted some questions from there. But for this new examiner, this Okorie's badge that will go and give us an idea of how the exam pattern will be. But by and large, I think he touched everything, and the interaction was quite interesting. Let's find time to go through it. Definitely there'll be MCQ questions a lot from here. But for orals, I'm not sure for now. But I think if it were to be the previous examiner, I'm sure he would have brought SGLT2. There was a time he brought circuitry, and over time, clinical pharmacology actually comes up. But we don't know this one, but it's good for practice and then to keep our mind updated. Thank you again, Dr. Felix. So let's get to the MCQ. I'm trying
Thank you for the opportunity.
Thank you. Thank you, Felix. Thank you. God bless. Over to you, Dr. Felix.
All right. Thank you, Chief Okopi. Thank you for words of advice and encouragement. Thank you for always being available.